All right, Katie. We talked a little bit before, but still, like, can you introduce yourself for the audience?
Yeah, for sure. I'm Katie. I'm a physical therapist and a strength coach, and I'm co-owner of Old Bull Athletics in Miami, Florida. We have three locations. We are a hybrid rehab and training facility. Kind of like the thing we say all the time is our goal when you come into Old Bull is that you would see everybody working in the space and not know who is doing training or rehab. So we really believe that the training and rehab exist on the same spectrum, and that's kind of our mission to really give people the type of like quality of care that they deserve. And then in addition to that, I wear a few other hats. I'm a neuroscience faculty member, actually where I went to undergrad. So it's a cool full circle moment. So I get to teach neuroscience, which is kind of like my first love before I became a PT. I was in the research world for a while before transitioning to clinical work, and deciding I wanted to be a PT. So it's cool to get to do both. And then what we were just chatting about, I get to travel and teach seminars, which is probably one of my favorite things. And I really focus on trying to kind of like level the playing field for training and rehab and show coaches and rehab providers that, man, we actually do so much more of the same thing. And if we put our heads together, we can actually help people a lot more than like separating our industries and making people think that like only PTs see people in pain. That's just not true. Trainers and coaches see people in pain for a lot longer, well before we ever will, and making people feel comfortable navigating that. So those are kind of the things that I'm really passionate about.
Nice, nice. So, before we dive into uh training or rehab, like, so what exactly do you teach about like neuroscience?
Yeah, so I teach a few courses each semester. The main courses I teach are behavioral genetics, so kind of just like how the environment impacts how we express our genes. I also teach neurobiology of disease, so from the cellular level, how the nervous system starts. That one's a little bit tougher, probably students' least favorite courses. It's pretty challenging. I teach a senior seminar in neuroscience, which I really love. Basically, the first half of the semester, I pick articles for the students to go over, and the second half, they pick them. And it's just really making sure that, like, before graduate school, these students are really prepared for looking at literature, understanding what it means, finding a good study versus maybe a not so good study. And then a couple other courses, neurobiology of disease. So, any disease system that affects the nervous system. Those are the main courses I teach. I'm pretty lucky where I teach. I have a lot of control over how I make the curriculum. So I get to weave in a lot of clinical stuff, which I think the students really like because most people aren't just like majoring in neuroscience for fun. They're usually trying to go on to graduate school and most likely be in a clinical type role. So that's been really fun to integrate the two.
Nice, nice. So, what got you into being a PT and a strength coach?
Yeah, so I mean, I've been an athlete my whole life. I'm 34. I started strength training at 14. And before that, I was a big time runner. I played lacrosse, I did gymnastics. And when I got to high school, I started rowing and I fell in love with it immediately. Like no sport had really gripped me like that. Like I just fell in love. And this is the early 2000s, and we had what I would say is a coach way ahead of his time who got us in the weight room twice a week, every week, in addition to a ton of rowing, obviously. And I just fell in love. I was a small kid. I was pretty teeny tiny, and finding that I was pretty strong for being small was this like aha moment. Like I just became obsessed. So I've always loved strength training, and I got a personal training certification throughout college. And obviously was rowing in college and got exposed to really good training there too. And I kind of always was like writing workout plans for people and training friends and then becoming a trainer. So I always it was interested. But I actually did not know I wanted to be a physical therapist until after I graduated college. So a lot, I share this story with students a lot too. I took 3 years between undergrad and graduate school. And I think that's an important message. Like we get this idea like, oh my gosh, you have to go right into your professional degree immediately. And I took my time and I'm really glad that I did. But I was in the neuroscience research world for a while. I kind of did all of my undergraduate studies, publications, conferences, research fellowships with the expectation to get a PhD in neuroscience. And I was working in a really great lab. It's called the Miami Project to Cure Paralysis. And it's a kind of cutting edge research facility focusing on traumatic brain injury and spinal cord injury. And every day I would go in and go down to the basement and go to the lab with the rats. And I would pass on the first floor this beautiful state of the art rehab facility where there was this badass physical therapist, Dr. Field Fote, who was a dual researcher and clinician. And she was actually doing the research that I was doing with rats, but like actually applying it to the humans and helping people. And I had this aha moment of like, wow, okay, so if I'm a physical therapist, I can be in academia and research and work with people. I don't have to just be with rats. And it was this like aha moment that I had and I completely rerouted it. It was literally just from walking in every morning to go on my microscope and see what was actually happening with the clinical trials that completely made me have a pivot.
Nice, nice. So, um, you mentioned that training and rehab should look the same, and uh, that's probably not the case when it comes to like working, at least in my experience with working with a lot of PT or working with a lot of athletic trainer. So, can you kind of like talk me through about this, like, uh, this idea and like maybe give me some example of like rehab and training?
Yeah, for sure. So obviously, every setting kind of defines things a little bit differently. And I know in an athletic population, like in a sports population, there seems to be a little bit more of these like siloed roles. What I would say is a little bit different about my philosophy and our philosophy at Old Bull. I'm really a big proponent of making sure we're using the highest level of evidence of any intervention we impart on somebody and doing it in a way that actually like feeds physiological adaptation. So one of my biggest gripes with rehab is it's very underdosed exercise that's often overcomplicated. So it's like stand on this ball, close your eyes, like juggle 17 different things. Boom, you did ankle stability rehab. When in reality, like we probably just got to get your calves crazy strong. We need to make sure that you can tolerate landing from a jump. We need to make sure you can tolerate taking off from a jump. We need to make sure you can strengthen that foot and that ankle in every direction and everything else in your body. So to me, that looks a lot more like training. And I have this big gripe with like, if we know the hallmark of resistance training is to impose a stimulus that's great enough to create an adaptation to make change, why are we not doing that in rehab? If we have people with injured tissues, if we have people with lower functional levels, those people need progressive overload more than anybody. So if you walked into Old Bull, it would look a lot like training because the two questions I kind of make my team members ask themselves when they're thinking of any intervention they're working on. Am I creating a physiological adaptation? So am I doing something hard enough to make a change? And then am I also creating a psychological adaptation? Am I doing something that's slowly over time etching away at this person's maybe like preconceived fears about movement, maybe the not so great stuff they were told in the past about their injury, like the horror stories we all hear, right? I had a disc herniation 20 years ago. My doctor told me to never bend over again. That stuff sticks with people. So instead of laying somebody on a table and stretching them and doing a lot of passive things that aren't changing their tissues, we're going in the other direction and making sure we're moving, making sure we're getting psychological and physiological change.
Nice, nice. So does that uh so that sound like this is stupid, but that sound like you're doing a lot of mm, not necessarily like max strength, but something like that, right?
Just depends, right? Like if I have a client who they have an injury and they need to get back to training, that max strength is important. Hell yeah, we're doing it. Just depends on their goal. So very individualized, but you can also think of it like we try to think of somebody coming to us with pain as also a window of an opportunity to help make them healthier as a whole. We have a pretty big crisis in the world of people not moving enough, people not having enough muscle, people not having proper and metabolic health. A lot of big picture things that contribute to obviously extremely high healthcare costs, long-term declines in quality of life and care. People are living longer, but they're living sicker longer. So a big thing that we try to think of also is how can I make this hour with somebody the biggest bang for their buck to helping their pain, but also helping them get healthier. So I think the onus is on people in like us in these professions to also use these as opportunities to educate the importance of movement and to give people more muscle mass, to improve their aerobic system. So I'm thinking of those things every interaction I'm working with a client. So if you think of what it takes to be a healthy human, you got to have max strength, you got to have endurance, you got to have that strength kind of in the middle. You have to have a good aerobic system. You have to be able to tolerate jumping. You have to be able to tolerate moving in different directions. So I don't consider like rehab ending necessarily. I consider training for like the long term and for life being really what takes over after we kind of get through maybe their more acute symptoms.
Nice. So, can you take can you share with me your thoughts on like uh some mini band glute activation, those type of stuff? I mean, because obviously like Coach was my mentor and uh he always said like rehab should look like training. So our approach to like rehab is a little bit different than I'll say most of the PT or AT out there.
Yeah.
And there are some like I don't know, some coaches or some PT like to use that, and some coaches and some AT don't. So
Yeah. Yeah. So I think of it in a couple ways. Like, ultimately, it really depends on what our goal is, right? If we're trying to really actually strengthen glutes, doing a banded exercise where you're almost just like maximally contracting and shortening them so you feel them a lot isn't necessarily contributing to strengthening them. Some people like how it feels to feel like a little bit of a glute contraction before they do stuff. Cool. That's a good tool. When you work with groups of athletes, stuff like band drills are really, really easy to get a group of people to do. So sometimes that's helpful too. I'm not necessarily against those things. It's more like my decision making comes from how can I pick the best thing to do today? And that's not necessarily exercise selection. I'm thinking of stimulus. So I don't really care selection as much, more of just is this an appropriate stimulus? And does it like align with their goal? So if I'm trying to think of things that move the needle the most physiologically, I probably wouldn't pick a band because it's not really going to strengthen you. However, if people love this stuff, I'm also not going to take it away from an athlete who loves it. Like I think we can go too far in that direction and just be so in our heads of like, well, the evidence says that this doesn't actually strengthen the glutes, and what are we even doing? Like, who cares? The person in front of you isn't a research article. They're a human that likes stuff and maybe has preferences. So it might not be the first thing I select if it's not really aligning with the goal of the session. But I don't think it's something that is so terrible that like nobody should ever use bands, if that makes sense.
yeah, yeah. What about like they're saying like, oh, the glue is not activated, the glue is not firing.
Yeah, that's a tough one. I think like that's another example of I think probably things that started well intentioned took a turn, and then now people think that, oh my gosh, I have no glutes, they don't work. If they weren't firing, you wouldn't be standing. So unless somebody has paralysis, it's just incorrect that they're not firing. A very common pattern, however, that we see in people with maybe history of back pain or history of hip or glute pain or knee pain is that we start to move in ways that bias certain muscles and decrease our use of other muscles. Not to say that they're turned off, but we start to move in a way that doesn't really challenge them, and they can get weaker, and our connection from our brain to the muscle can get weaker. So that's more of what people are, I think, trying to say. Not that they're not, not firing or not necessarily working, but it is common that a lot of people struggle with like feeling their glutes when they exercise. So these things can kind of perpetuate and become misnomers that people think are like, oh my gosh, I have dead glute syndrome or gluteal amnesia. Um, and luckily, I think we're getting away from that a little bit, but that's where a lot of that banded stuff comes from because what makes you feel a muscle a lot is shortening it and squeezing it. So in a banded exercise or in squatting with your knees pushing really, really far out, all we're doing is just really, really shortening those muscles and making the contraction really noticeable. So for people who historically haven't really felt that, they might think, oh my gosh, I really need this, or else my glutes are off. So it's not that they're off. We wouldn't stand if they were off, but we can move in a way that makes them less strong. We can have less awareness of them, and we can train in ways that bias those muscles a bit more.
Nice, nice. I love that. I love this. So, talk to me about like I was talking to another like physical therapist, not just one, a group of physical therapists, and then like we were talking about like uh injury mechanism, especially like ACL or Achilles tendon.
Hmm.
And when it comes to ACL, like you got a lot of like maybe uh deceleration, certain type of movement, and or it's a contact injury, right?
Hmm.
Talk to me about your thoughts on knee valgus.
Okay. Yeah. Yeah, I think that's another thing that I think kind of became this like evil thing for a long time that people really, really like. If your knee caves in, you will die. Like it is terrible immediately. And what's challenging with a lot of this stuff is people also like to think that, man, if I just train somebody in this really, really perfect way all of the time, they will never get injured. And we know that that's not the case. I always tell clients too, like just like I can't prevent you from walking out the door and like tripping on a curb. I can't prevent an injury from ever happening, but we can train in a lot of different ways that gives your brain and your body a lot of options to handle stress. So you maybe can have more success or more options when you're put into like a reactionary situation, like being on a field, for example. So knee valgus can be an example of that. So, and it's also important to like, anytime our knee goes inward, it doesn't mean it's valgus in the way that I think people talk about it. Collapsing inward and like just dropping all of your weight and your load into like the inside of your knee because you don't have the strength to maybe maintain a different position is very different than like the knee moving in and out. And even still, we actually don't have a ton of evidence that valgus is as dangerous as we once thought it was. I think of it in a few ways. Like the more options I give somebody to train and be successful in when they're out in the training in the gym is very laboratory setting, right? It's perfect, it's curated. I can make it look the way that I want. Being on a field is the opposite of that. It's complete chaos. So what's really important with training and rehab is to try to have some like organized chaos and try to not get so in the weeds with how people land and how people move. Because if you ever watch an athlete, if they jump and land, do they ever stick the landing perfectly in the way that we teach them when we're working with plyometrics with people? No, they take several steps. They collide with the ground and the ground pushes back against them. There's reaction forces pushing back and it can be completely unpredictable. Then you have bodies around you as well and a ball. So, and field conditions and stress and the crowd, all of these things that we can't ever possibly perfectly create in a rehab setting. So if we get the body really, really strong to kind of tolerate the moments when something like valgus happens, that's our best bet to help people feel safe and secure. Again, I can't prevent injury by any means, but that's a way to kind of think of it. So knee valgus isn't really supported in the literature for being as dangerous or how we're taught it in PT school. It's an overcorrection, I think, of things very, very long over time being deemed as dangerous. So if it's something that like if I have a client who's experiencing a little bit of, I don't know where that came from, but that thumbs up, a little bit of like inward knee travel in a squat, a lot of times it's just your adductors helping you get out of the bottom of a squat. So it's not something I really even make a point of unless somebody has symptoms or pain. So I'm not in the camp that valgus is dangerous. I'm in the camp of we got to make our body move in a lot of different ways. We got to get it really strong and not demonize certain movements because not all injuries are 100% biomechanics. I would venture to say no injury is 100% biomechanics. It's all a cluster of things, and very, very often it's many of those other things in the cluster.
Cool. So, uh, I like I like that you said like not all injuries because of biomechanics. Talk to me more about like what are some other factors?
Yeah, absolutely. So, pain is super complex. Injuries are super complex. I mean, if we had a way to know exactly what caused them, we wouldn't have jobs. Like, it would just be so easy. Everybody would be like, okay, don't do these things. I'll never get injured. It's fine. Um, there's a lot of psychology involved with injury too, even contact injuries. But if we just think very broadly, like the general aches and pains that people get, our past experiences with pain have a big thing to do with our likelihood of being fearful in the future and that potentially maybe changing how we move or guarding ourselves. So that's a really big thing. What people have told us in the past about pain and injury are big things to consider as well. Like I mentioned, kind of that we all have those clients and patients who come in who are like, yeah, my doctor said I could never put my arms over my head again because I have like a slight rotator cuff tear, or I had a disc herniation in college and I haven't deadlifted since. So we get that stuff all of the time. So that's a big part of it. Another big part of it too is just tissues not being strong enough to tolerate what you're asking them to do. And I say strong, not just meaning strength, I mean also just like the capacity of them. So if you don't train in a way that looks anything like what your goal activity is, or you don't do it long enough to build consistent adaptation and tolerance over time, if your body's not ready for something, you're going to know about it. So that's the good thing with that too is all of this stuff is actionable, right? Like it's very actionable. I can work on somebody with the psychology side of it. I can decrease their fears over time by showing them that training is fun and giving them positive experiences with stuff that maybe they were scared of before. And then I can also develop resilience and capacity and tolerance to do stuff. I would venture to say that in the absence of trauma and red flags, so not talking about contact injuries and not talking about like scary neurological red flag stuff, most pain is likely due to somebody asking their body to do something that they were not ready for. So their quad muscles weren't strong enough to be able to tolerate the deceleration. Their ankle stiffness wasn't quite there to tolerate sprinting. They haven't played a sport since high school and they're 40 and they joined a pickup soccer league. They're not too old to play soccer. They haven't done it in 20 years. So it's a lot of this kind of not training in a way that actually matches the demands of what you're asking your body to do.
Nice. So apparently like a lot of pro sports are looking into the biomechanics lab and a lot of PT are I don't know, maybe they're doing this for a long time. They have this motion capture or what they call biomechanics lab look into like why injury happened. And I was talking to like a few tendon expert or like some biomechanist about like uh this biomechanics lab. Some of them think that like not some of them, probably most of them think that we're not really getting the answer we want out of like these what's so called motion capture biomechanics lab. What are your
Mhm.
thoughts on this?
Yeah, I think like in PT school we're taught a very like biomechanist lens of how injury happens. And that's persisted for a very, very long time. And I think it's going to continue to persist. It's getting better. I'm in a little bit of a bubble because I think my algorithm shows me more of the stuff who of people who maybe don't think as much that way. But it's definitely still exists. So if we even just think of beyond like actually at this point we do have a lot of evidence that like deadlifting with a rounded spine doesn't increase injury risk. We have a lot of good evidence of things like that. Even if we don't look at that stuff, if we think of the one simple thing that every single person has individual anatomy that will relate to them moving in a different way, we can't possibly think that a perfect box exists for how we can move. Um, think of you and I, for example. Our femurs are probably different lengths. The way my hips sit, like the way that my femurs sit in my hip sockets, is probably different from yours. Our tibia and fibulas are probably different lengths. Our torso to leg length ratio is probably different. My hips are probably wider. Like all of these things, there's no world in which we would ever squat the same way, that we would ever sprint the same way. There can be common themes that I think we need to do a better job of maybe explaining why they matter. So, like, I think of it as form and position. Instead of there being a right or a wrong way or a biomechanically correct way or not, think of it as a strategy and an option that can relate back to a goal. Kathy Sierra, she actually works with horses and she talks a lot about ecological dynamic systems theory, which is just fancy ways of saying like she has great quotes on this. She wants to make her horses, for example, biomechanically abundant, meaning I want to have a lot of different options that my body can move in. So when push comes to shove, I have tools in my tool belt to be able to tolerate whatever stress is coming at me. So, me, for example, I'm a very hip dominant athlete. When I do anything, the power comes from my glutes and my hamstrings. Relative to my glutes and my hamstrings, my quads are not as strong. So, that shows up in how I move. So, when I squat, I'm a lot hingier. When I do anything, I'm a lot hingier. And that is my position of strength. So if I'm in a stressful position, let's say I'm playing a sport and I'm really fatigued and I'm really challenged, my body's going to revert to the pattern that's strongest. And for me, that's hinging. So I want to keep that pattern, but I also know I need to train being more upright and train my quads because I don't only want to have a hip strategy, I need a knee strategy too. But I don't only want to train a knee strategy because I'm already good at hip stuff, because I need to keep that strong. Because I want my body to be able to do what it's best at when fatigue is high, when stress is high, and when I'm in like kind of a precarious situation athletically. So if we think of biomechanics that way, I think it broadens the definition a bit more. We want options. We want people to be like really strong in their like pattern of preference, but also give them other options too. This becomes the conversation can become more nuanced and difficult for sprinting, for example, because there are a lot of things that can show us if somebody's being efficient or not. But I think we have to get away from labeling things as correct or incorrect and maybe efficient, less efficient. And that I think can change the narrative a little bit more.
Uh, Talk to me about like what are some stuff you think like what are some stuff that people talk about like come when it comes to sprinting? What is efficient, what is not efficient?
Yeah, and with all this stuff, there's still nuance. Some general things, though, if you have tension everywhere in your body instead of being relaxed, that kind of works against you. So if you watch people, like I was just watching when they were doing a lot of the coverage of the combine, and you see that people, they're all fast, they're all freaks. It's amazing, but you can see a difference of how like rigid and almost like muscularly people are trying to push through versus the people who are fastest. They have a pretty relaxed face. It almost looks like their head is just bobbing and they're just chilling. And so relaxation, it's counterintuitive, but not having too much tension when we sprint is really important. That's why it's hard to teach sprinting because we think, oh, if I need to go fast, I need to try really, really hard. Or if we work with, like me, I'm a little meatball. When I sprint, I try to just like muscle through it as much as possible. And that isn't as efficient. So developing tendony qualities in people, stiffness, hitting the ground really, really stiff and making like as minimal of ground contact time as possible because of that stiffness, instead of really absorbing force and then having to muscle your way out of every step. That's efficient. So, tendon health, stiffness, elasticity, that's efficiency. So, that needs to be trained. We see differences in more muscular strength runners versus more like tendony, springy runners. So that's a big part of it. Also, running is very, in sprinting in particular, the angles matter a bit more. So we know that when we're accelerating, we're leaning forward. We know that when we're at top speed, we should be pretty upright. We know that we should be, as I mentioned, hitting the ground hard and trying to get off the ground as quickly as possible. So those are things that are efficient. We know with running, there's actually more of a rotation to it, or with sprinting, I should say. There's more of a rotation to it. If you watch sprinters, it almost looks like they're moving diagonally. So those are things that help with efficiency. We could talk ad nauseum about this, but those are just some things that really stand out. I think a big thing to consider for a lot of people is to help identify in yourself and your athletes if they seem to kind of fall in the bucket of being more of a muscular and strength athlete, not necessarily just by looks, but how they move. So versus being a little bit springier, a little bit tendonier. Like we tend to kind of know that about ourselves. Like I'm not super springy and I had to develop those qualities. I'm naturally more of a strength athlete. And then conversely, I can work with people who are crazy springy, but we need to build up their strength. So that's part of a way of thinking of it too. Like, how can you level up your qualities to be more efficient as well?
Cool, cool. So I want to backtrack a little bit when we talk about knee valgus. You say like
Mhm.
you mentioned that maybe it's the adductor helping you get out of that position. When like if you look at traditional like anatomy, actors like they'll say like it's probably because your adductor is too tight or too activated, so they have knee valgus. Talk to me a little, talk to me about that.
Yeah, that's an interesting perspective of it. I would think of it as so the way we can think of our giant adductor muscle groups, they're huge, they're big. People think textbook wise, yeah, they just kind of bring the legs together. And then if they're too tight, they have a hard time helping the legs go apart. As we get in different ranges of hip flexion and extension, so down to the bottom of the squat and coming out of it, the adductors actually become more like hip flexors and hip extensors. So that's a big thing anatomically from a more functional way to think of it versus like just in a textbook, that they're huge muscles and they're a big driver of force. Getting you out of the bottom of a squat, those adductors are helping big time. Anybody who squats really, really deep, or maybe they do for the first time in a while, it's the adductors that usually get really, really sore. They're a huge, huge, huge hip flexor and extensor as well. So that's a big thing to consider. From the bottom position, you can almost get a little bit of like adductor whip to help you get out of the hole. You could maybe potentially say, like, okay, maybe this person is trying to avoid loading the quads as much to help them get out. So they bias an adductor whip. You could argue that a little bit too, but it's a very normal anatomical thing to have those adductor muscles help us. It's why they're so important. It's why they get strained a lot too, because they're typically not trained. Or they're trained at a much less level compared to other stuff. Like we think of all of our accessories, people are doing leg extension, leg curl, not a lot of people doing hip abduction and adduction, or they're just using the machine and that's kind of it. Or they're kind of begrudgingly doing Copenhagen's, but not really with intent or not loading adductor movements in different patterns. So I'd venture to say it's a bit more of them helping us actually out of the hole than it being problematic.
Uh, y- you mentioned like there's a lot of adductor strain, but since adductor is a huge like hip flexor or hip extensor, why would you load it at the Copenhagen or like a adductor position?
Yeah, because you want to train it in every plane, right? So if the adductors do a lot of stuff, they like textbook open and close the legs or resist opening and then closing the legs. Yeah, I need to train it that way. And I need to train them isometrically in a Copenhagen. I need to train them with eccentric focus. I need to load them up and train them concentrically. I need to train them slow. I need to train them fast. I need to train them in ways where they're like synergists and assisting with movements, in ways where they're the prime mover. We need to do it all. So for me, I think of it like if I have a muscle group, I need to make sure I'm making it as well rounded as possible. So we need to, do machines. We need to do isolations. We need to do isometrics. We need to do fast stuff, slow stuff, eccentrics, all of that. They just do so many things that if we don't train them well, that's where maybe things can come up.
But if its main function is hip extension, hip flexion, why not we train it at like train it more like a hip extensor and hip flexor? So
Oh, for
maybe
sure. Absolutely. Yeah. When I say like train it every way, that's what I mean. So any way that the muscle can work, we got to train it that way. And it's, that's where people can get, I think, really in the weeds of like, this exercise is for adductors and this exercise is for quads. I don't really care about that. I'm thinking big picture. I need this person to move in as many planes of motion as possible. I need them to do it fast, slow. I need them to do it with like steady strength, high rep ranges, low rep ranges. I need them to jump. I need them to do everything. So it's less about just like this perfect exercise selection and more of how can I train this, the goal that I'm working on, and how can I train for a stimulus? How can I train for an adaptation? So yes, the kind of, I guess, cop out answer to all of this is like, yes, do it all. Like we should do it all.
nice, nice. All right. So last part of this podcast I want to talk about uh evidence-based practice. So in the last few years, well, I was originally from Taiwan. So
Mhm.
in Taiwan, like RPT, we don't, I don't know why, but like we don't really, at least like when I go to PT, they don't really quote a lot of like research or like I don't know, maybe not as like research based as it is in the state. I'm not saying like, well, I am kind of saying it's I don't know. But uh in the last like 2 to 3 years, ever since I moved to the state, there's a lot of like PT talk about this evidence-based practice or research-based practice. And a lot of time it just like we meant a lot of time it's just minivan. A lot of time it just like yeah, knee valgus hurts his knee or yeah, hamstring strain you need to do Nordic hamstring curl. Adductor strain you need to do Copenhagen. And I do feel like this research-based practice is not as helpful as people think it is.
Yeah.
So, like, I mean, you have like plenty of years of experience like treating people or like training people. So how do you balance that?
Such a good question. And I gotta say, you think it's just Taiwan not practicing with research? It's everywhere. I would venture to say that a lot of the rise of social media in the training and fitness and rehab world, um, I think aligns with people coming out of PT school and bucking back against what they were taught, and kind of a lot of times wanting to talk about how bad PT school is. And there's a lot of things that have room to be improved upon for sure. Evidence-based practice, I think I agree with you. I think the pendulum can swing too far. I think we can get people who are spitting out PubMed IDs instead of thinking about the individual person in front of them. And a lot of times, I also think it can be posturing for other providers to be like, look how much research I look at, but your patient has no idea what you're talking about. So I come from research and I'm a neuroscientist. I love research and it's very, very important. But just like there's a hierarchy of evidence, so like we know that meta-analyses and systematic reviews are like the bread and butter, the highest level of evidence for us to put trust in what a study says. But there's other rungs on that ladder too. There's smaller studies, there's case studies, and there's expert experience and there's expert opinion and clinical experience. All of that stuff is important and it all matters. So I think of it, and I know people are kind of using this term a little bit more now of evidence led or evidence informed, just kind of meaning that, like, when I'm working with a patient, I'm taking all of that stuff into consideration. I'm taking what the research says. I'm also understanding that research is limited. And quite frankly, there's a lot of studies on rehab that I don't necessarily tell us what they think is telling us, because if we're being honest, a lot of these interventions are very low level, meaning like, what is the physical therapy intervention that they're studying? Sometimes they don't clearly define it, and sometimes it's a very low level rehab program. And I don't think that's super helpful when we're trying to actually compare, like, does this help somebody or not? So that's stuff that's important. We have to know. That's why I teach this in my classes. You have to know how to look at research and see, is this garbage or not? Like, is this telling us what we think it does? So being evidence led or evidence informed is taking into consideration the literature, taking into consideration the studies that have been done on these topics, but also understanding that there's limitations. And then another side of evidence informed or evidence led work is also looking at more of, I would say, like the exercise physiology principles that are very, very well defined at this point. And that's what I think of a lot of as well with evidence, where like, I know I need to make an adaptation happen. Okay, how do I do that? Progressive overload. I know I also need to not overtrain somebody. How do I do that? Okay, load management. So there's a lot of these principles in exercise science and exercise physiology that are very, very well defined that we should be utilizing for our exercise selection and intervention. Then another like component of of evidence-based or evidence-led or evidence-informed care is just caring about the person in front of you. So at the end of the day, none of that stuff matters if you're not creating a plan for the person in front of you to make them feel heard, to make them feel safe, to have it align with their goal, to help them get their identity back after pain. It doesn't matter what all of these studies show. if we can't actually just have a conversation and make somebody feel safe and heard. So that I think gets lost sometimes. If we just operate by looking at research articles, we're not going to really like actually create an experience for the human in front of us. So I think that's a very important thing. What is cool, I think, in some of the things that are happening more in like the rehab literature now, we're having more evidence and more studies being done on client communication and the psychology of rehab and the psychology of pain. And that I think is very powerful stuff. Where learning how to speak to people who are in pain in a way that validates their experience but encourages them and empowers them. That's awesome. And that's stuff that we're learning from the literature on like communication and psychology. So there's important stuff in the evidence, but there's also stuff that just like being a human and being present with the person in front of you and not forcing them to do this perfect protocol that you found on PubMed. I don't think that's always the answer. I'm in very much agreement with you.
Nice, nice. All right. That's all the question I have for you today. So for those who are interested in what we're talking about today, where can they find where can they find you?
Yeah, Instagram is the best place. So my personal Instagram, KT Dabrowski, or Old Bull Athletics, which is our gym's Instagram page. That's where we'll have any information about upcoming courses. We host a lot of courses and do our own at Old Bull and travel for them. Any cool podcasts that I get to be on, that's where that stuff is. And if people have questions, it's a great place to reach out as well.
Nice.